thank you for joining us today. And before we get started, I want to thank Jazz Pharmaceuticals, who is a sponsor of this important webinar on sleep. We're here to talk today to continue our conversation about the importance of sleep as it relates to cardiovascular disease. But as Dr. Ellen and I just talked about, it's related to everything. So we'll get more into that. And we began by focusing more on this topic last year after sleep was added as the American Heart Association's Life's Essential 8, an element of healthy living. So with this recognition of sleep as a fundamental element of our health and well-being, we know more now than ever that developing healthy sleep habits is an essential part of taking care of our hearts. So over the past year, we've expanded the conversation, learning about how sleep impacts our heart health, discussing heart failure and sleep as a specific example, and exploring how sleep disorders can interact with our heart health and heart disease. So today, we're going to take the conversation one step further to learn about sleep apnea and narcolepsy and their effects on cardiovascular health. We know there is an association between these sleep disorders and higher cardiovascular risk, but we will use this conversation today to learn more about why this is and hear from Dr. Allen about actions that we can take to stay on top of our heart health as we protect our sleep. And here to shed this light on these sleep disorders and their connection to heart health is Dr. Christopher Allen. Welcome, Dr. Allen. He is a board-certified neurologist and sleep medicine specialist based in what I heard just this morning is Chile, Michigan. So thank you so much, Dr. Allen, for being here, and I'll turn it over to you.
All right, Selena, thank you very much for that. And so again, one, I'm really excited to be here. I love talking about sleep. And so, yeah, as I was saying before this started, sleep definitely affects everything, especially the heart. And so we're talking about the importance of sleep along with like your heart health. And we can go to the next slide. And so again, you heard Dr. Christopher Allen. And so on the next slide, who am I? So, as mentioned earlier, I'm a board certified pediatric neurologist, but I've did my fellowship at the University of Michigan with sleep medicine. So I am treating adults and pediatrics as well within sleep medicine. And the thing is that, one thing I love about sleep medicine, it shows you how to take care of sleep from birth to death. And the thing is that as soon as I finish, I still love my pediatric neurology. And I always tell people that sleep is my passion. And I love working with the adults in the platform that I've had and the patients that I've treated. I've loved that. And some other shameless plugs with me as well. So I live in Saginaw, Michigan. That's like an hour and a half north of Detroit. Growing up in Saginaw, you learn to say that whole line. So everyone's like, yeah, I know where Detroit is. But I guess I can say half an hour from Flint because unfortunately people know about Flint as well. But with that being said, I've been practicing here for 7 years. And as of January 2024, I'm going into private practice with my own practice, which is called Quality Sleep and Neurology. So, hey, stay tuned on that. And another shameless plug.
Congratulations.
I appreciate that. Thank you. It's exciting and scary at the same time, but I love it. And with that being said, not only am I a sleep doctor, I'm also a sleep influencer. So you can catch me on those internets, on social media. I'm on Instagram. I'm also on Facebook and LinkedIn. And the name is Sleep Dr. Chris. Easy to remember. So if whoever's watching, you want to take your phone or just put in Sleep Dr. Chris, you can find me, like, and follow. Enough of the shameless plug. So next slide, please. So when people ask me, you're a sleep doctor, so what do you do? So I always joke with my patients and my colleagues, I'm a sleep doctor. I'm not a sleep apnea doctor. Sleep apnea is only one part of sleep medicine. So what I did, I just showed you all my expertise in a little bubble. When we study for our boards, this is what's shown here. And every time I do a talk, I always just tell them, it's like, look, it's more than just obstructive sleep apnea. So there are other things that you can talk about as well. Next slide. See, it's even more. So with that being said, we can go to the next slide. So enough about that. So I'm going to come to why you guys are here. And it's the importance of sleep for heart health. Now, before I even start talking about the two disorders that I'm going to highlight in the short talk, and we're going to have time for any questions that you guys have. Um, the bottom line is getting enough sleep is essential for overall health, but it's especially important for heart health. And with adequate sleep, it helps you to regulate your blood pressure, heart rate, and also inflammation levels. And if you think about inflammation levels, those can actually, worsen the heart with high blood pressure. It also protects your blood vessels from damage. So if you don't get enough sleep, what can happen is your stress hormones can be increased. And if you think about that, that definitely can raise your blood pressure and then also increasing those risks of heart problems. You can go to the next slide, please. So you're saying, all right, Dr. Allen, you want to get, adequate sleep. So how much is that? So most adults need around 7 to 8, and actually, honestly, 7 to 9 hours of sleep per night. Now, some people might need more or less, but it's really important to listen to your body and get the correct amount of sleep that you need to feel rested and refreshed. That is the most important part from that. And if you're not sure how much sleep you need, talk to your doctor, talk to your provider to make sure, for that. And I always tell people, you got to have grace with yourself. Now, I'm telling you this, and I tell my patients that they look down. I was like, wait, but I only get 7 hours of sleep, maybe once a night. Give yourself grace. And I usually tell patients that, look, if you're not getting that now, I'm not telling you to go home right now to get it, but let's find out, why is this happening? Is there something precluding you from getting the amount of sleep that you need? And honestly, like you look, Dr. Allen, it's like, I just get 6.5 or 6 hours and 40 minutes. Like if you're doing that, you're waking up, you're feeling refreshed, you don't have any diagnosis that you're concerned about from there, no high blood pressure, no cardiovascular disease, then that's fine. I always tell patients, like, if you're sleeping well, if you're okay, I'm okay. Now, some of the people that are like, I sleep 5 hours and I can be all right. But then I'm looking at their list and they're on two different high blood pressure medications and they're not controlled. I'm like, well, let's look into see why you're not getting that quality sleep. Next slide, please. So, the first thing I want to talk about, something that's near and dear to my heart, is obstructive sleep apnea. Now, I know you probably heard about it before, but I'm going to talk to you like you've never heard about it. And so now you get to step in Dr. Allen's office. And this is what I usually tell my patients. So the same thing I'm telling you, if you see me as a patient, I always start from ground zero, saying even if you are a high level extra, specialized doctor. I was like, nope, we're starting at ground zero. So you know where I'm coming from. And so this is you stepping into my office. So obstructive sleep apnea. When you fall asleep, all the muscles in your body relax. Your legs, your arms, even the muscles in the back of your throat. So if this is your mouth and this is the back of your throat, when you're awake, airway's open, air's going in and out, no problem. But when you fall asleep, the muscles relax and right in the back, it gets small. So when you're sleeping and breathing in, this is the sound people hear. That's how snoring happens. So all of a sudden, even though that's happening, that closes and then airways close. So no oxygen is going to your heart, your lung, or your brain. But they don't know what's happening back there. So your heart's working harder, lungs are breathing in deeper. Your brain sending all these stress signals all over your body that can actually raise your blood pressure. And then all of a sudden, you wake up. Well, not you, your body. Sometimes you. So you fall back asleep and it happens over and over and over again. That's obstructive sleep apnea. It's the complete or partial obstruction of that upper airway. And that repetitive, episodes of shallow breathing or pausing in your deep sleep. And as I said, if it's closed, you're not getting oxygen because of the apneas that are happening or that shallow breathing. And so oxygen is going down. And that's not good for yourself. That's not good for your body, and definitely is not good for your heart. And I always joke with my patients. I love World Sleep Day. I took this picture 2 years ago, and I do it every year. Is My office thinks it as an excuse to come to work in pajamas. It's just promoting sleep health. And there's this training we had this saying like CPAP is sexy, CPAP is sexy. So I kept that. So as you see this picture of me in one of my sleep masks, I will say CPAP is sexy. So next slide, please. So if you think about obstructive sleep apnea, how can you find out, if you have it? So the diagnostic criteria of finding out is having a sleep study. The official name for that is a polysomnogram, or if you hear polysomnogram or PSG, that's the sleep study that's happening. It's the gold standard. That's what you're going to use to find out if you have obstructive sleep apnea. A great part about it, you can find out if you have other sleep disorders with it. So that's why it's such a great test. One of the drawbacks with a lot is, insurance. Sometimes insurance might not qualify you to take that test because they want you to use something that's called a home sleep apnea test, a test you can do at home. Now, home sleep apnea test is a great test. And honestly, if I have a patient and I'm pretty sure that they have obstructive sleep apnea and I'm not looking for anything else, I'm going to do a home sleep apnea test. It's a great way to diagnose obstructive sleep apnea if you are the right patient. And that's the thing, you have to be the right patient for it. And a lot of people will get it and they're not the right patient. So and the other part about it, it's good to rule in obstructive sleep apnea, but it's not good to rule out. So if someone said that you passed your home sleep apnea test or it was negative, I usually think of that as inconclusive. So if you've been told that and you still feel like you're having symptoms and you feel super tired, or your bed partner is telling you that you're pausing and breathing, readdress it, because you probably need to go into the sleep lab to get that taken care of and to see if you actually can rule it in or rule it out from there. Next slide, please. So ways to treat obstructive sleep apnea. Again, we're stepping back into Dr. Allen's office. So I always tell patients that there's many ways to treat obstructive sleep apnea. People think about obstructive sleep apnea, they always think about that one treatment, but there's actually other ways. You can use PAP therapy, which is like CPAP or BiPAP. There's oral devices. There's literally a mouthpiece, a specialized mouthpiece, not the one that you get from the 800 number, a specialized mouthpiece that you can put in your mouth that opens up your airway. There's different types of surgery too, and there's also lifestyle modifications. The caveat with that one is that it depends on the severity. So if you have mild to moderate obstructive sleep apnea, losing 20% of your weight can actually get rid of obstructive sleep apnea. So when I tell patients, that's good, so I'll just lose weight. I'm like, well, you're not going to lose it tomorrow. So we still have to treat you while you are working on that. And going back into my office, the PAP therapy, or CPAP, stands for continuous positive airway pressure. That last word is the most important part, pressure. You wear a mask, and it provides a pressure to keep your airway open. So as I was saying before, the airway's closing, that pressure keeps it open. Air's coming in and out, no problem. Now, with that being said, that's why I'm really big on people getting treated for that, because there's ways to treat it. There's ways to correct it. And so that's pretty much, we'll have time for questions, but for obstructive sleep apnea. Next slide, please. So now I want to talk about narcolepsy. And the thing is, you've heard about narcolepsy. You might have heard about it in movies, and sometimes, they might portray it in the right way, but there's many times where it's like, okay, no, that's not really what narcolepsy is. And honestly, when you think about narcolepsy, it's something that's really serious because it's a chronic sleep disorder, which causes disruption in your sleep-wake cycles. It's something that will affect your brain ability to regulate that cycle. And usually people that have narcolepsy, you'll have excessive daytime sleepiness. So you're tired all the time. You have something that's called cataplexy. It's the sudden loss of muscle control that is triggered by strong emotions like laughing, anger, surprise. All of a sudden, you just feel it briefly and then it happens. And then you also have sleep paralysis, which is like literally you'll either falling asleep or waking up. You're up and you can only move your eyes and not your body. You're like, oh, what's happening? Now, with that being said, if that's ever happened, you can have that without narcolepsy. So I don't want to scare anyone to say like, I might have narcolepsy. That's something that can happen, but with all of that combined, that's usually narcolepsy. And then also you have something that's called hypnagogic hallucinations. That's vivid hallucinations that you have when falling asleep or waking up. And the part of waking up is actually called hypnopompic. So those hallucinations that are happening, along with all of that, there's a concern for narcolepsy. Next slide, please. So how do you diagnose narcolepsy? And so with that being said, it's you're involving the medical history. You have to get a good history because people come in and I'll see them and I was like, so how can I help you? He's like, oh, I have narcolepsy. And after getting that good history, I'm like, sir, madam, that's not narcolepsy. And so it's good about getting a good history. Then you have the sleep studies and then like a neurologic exam that's going to help with that. And the sleep studies that are used for that, as before, you use a polysomnogram or that in-lab sleep study that will record your brain activities, breathing, and other physiological parameters during sleep to help you get that diagnosis of narcolepsy. But the most important part is the next day, which you do something that's called a multiple sleep latency test, or MSLT. I call it, I always tell my patients, like, this is, you get a nighttime study and a daytime study. So during the daytime, you get 4 to 5 opportunities to fall asleep. And if you fall asleep, I look at that data and I can see if you have narcolepsy or not. And so it's just taking short 20-minute naps during that time. Next slide, please. So one of the things I wanted to talk about is just the treatment of narcolepsy. Now, here's the thing. To be, open about this, there's no cure for narcolepsy. As I said, it's a chronic disorder, but there's treatments that focus on managing those symptoms to improve your sleep quality, which is going to be important. And so some of those will be lifestyle modifications, making sure you keep a regular sleep schedule, making sure that it's adequate sleep, duration. Because a lot of people is like, well, they have narcolepsy, they'll sleep all the time. But you'll be surprised, like keeping that consistency is going to be something that will help. And then having scheduled naps, sometimes that alone can help even before you get to the point of medications. But the lifestyle that we live sometimes is hard where you have to do medications. And with that medications, it's going to help you manage those symptoms. So you have stimulants that will help you. You'll also have weight promoting medications that will help. You also have medications that can also treat and control the cataplexy, that sudden loss of muscle control that you can have. So narcolepsy can be challenging, but with the proper management, you can live fulfilling lives. You'd be surprised at the people out there. And if you, like I said, looking on the social media world, there are people that put themselves out there just showing how it is to live with narcolepsy, and they're just living, normal lives. You'd be surprised at the people in the world that just have it. And you wouldn't know because they're getting treated properly. Next slide, please. So, as we're talking about heart health and cardiovascular risk, what are the risks with narcolepsy and obstructive sleep apnea? And both of them are kind of similar. So I wanted to put them side to side so we can hear about that. And so let's start with narcolepsy. And here's the thing. Narcolepsy, it's been associated with an increase of risk cardiovascular risk factors, including high blood pressure, increased inflammation, and then metabolic abnormalities. But here are the ways that they can increase those cardiovascular risks. So with narcolepsy, you get fragmented sleep. Even though you're sleeping a lot, that sleep is fragmented. It's taken like a knife and just chopping it up. And what that happens, it leads to increased levels of stress, hormones that, again, can raise your blood pressure and even your heart rate. In cataplexy, those episodes happens when loss of muscle control, that can cause a sudden drop in your heart and your blood pressure. That will put strain on your heart as well. And as I mentioned, you have inflammation, which narcolepsy is increased, has been shown to increase levels of inflammation in the body, which can be a factor for cardiovascular disease. And for obstructive sleep apnea, again, the repeated oxygen dropping can actually lead to damaging those blood vessels, making them more likely to clog as well. Also can lead to increased inflammation because of those stress factors as well. And then if you're thinking, like, if you're holding your breath so long, your heart's going to rate, which is going to increase that sympathetic nervous system activation. So that fight or flight, like, oh no, something's happening. That's happening overnight with those patients. And that can lead to increased heart rate, blood pressure, and then also strain on the heart as well. So next slide, please. So what I've done, those are some of the references that I had to talk about that. I was told to keep that, brief so we can have the chance so we can answer some of these questions, because I can talk about it to everyone in the face, but when you have those questions, I think that's where the big knowledge comes in as well. So thank you for listening to this part. And so now we're going to open up for questions. And I'm going to take a sip of water while we're waiting.
Thank you so much, Dr. Allen. I was taking some notes over here because I learned so much in this brief time of you kind of really laying out what I thought was a real helpful comparison between what many of us experience in sort of dealing with cardiovascular disease, but also in some sleep deficits and some sleep issues. So let's talk specifically, because we are Women Heart, let's talk specifically about what this means for the women in our audience. Can you talk about what symptoms should signal to a woman that there's something going on out of the ordinary of just being a little extra tired, or, sort of just being a little bit out of sorts, is there a difference between, for example, being fatigued and being sleepy?
Most definitely. And I always tell patients this, like, there's such thing as called being fatigued, there's such thing as sleepiness, and you can have both. And I'm glad you brought that up. And just for a short moment, I always tell women, don't blame it on you being a woman. If you're tired, there might be a reason. It's not
Yeah,
because you're a mom. It's not because you're working in like a busy schedule. If there's something going on, that can happen. With fatigue, fatigue is that you have the willingness to want to do something, but your body just can't. You want that to happen. A lot of people with heart failure or even hypertension or cardiovascular disease, they can have that fatigue. It's like, look, I want to go up those stairs. I'm trying to. It's just hard for me to do so. With sleepiness, you're tired. You just want to go to sleep.
yeah,
You're tired. You won't even think about the will to do it because the will of what you want is to go to sleep. And as
yeah.
I mentioned before, you can have sleepiness, you can have fatigue, you can have both.
Yeah, it reminds me of when I first started having heart disease symptoms, and the difference it made for me was this idea between what I used to be able to do without even thinking, and what was labored. So walking upstairs is a perfect example of the difference. It's my understanding, Dr. Allen, that narcolepsy is one of these things that's very commonly underdiagnosed, undiagnosed, misdiagnosed. In your experience, what are some of the different diagnoses, let's say, that people may be given when really the true sort of underlying issue is narcolepsy?
And I'm really, big, about that as well. Because the thing is with narcolepsy, it goes in both ways. There's people that are diagnosed and after, examining them, and that's why I said in the talk, it's about getting a good history.
Hmm.
Everything starts with a good history.
Yeah.
And I've had patients like, oh, I have narcolepsy, or I'll see it on the problem list as like narcolepsy. If I'm talking to them, they pretty much have like obstructive sleep apnea. Or after talking to them, it's like, "Oh, you go to bed at 1 a.m., you have to get ready for work at, like, 3:30." It's like, "All right, let's get more sleep. Thank you for coming in." So there is, like, lack of sleep from that way. The other way around where, there might be a misdiagnosis where some people, like, might have mild obstructive sleep apnea. Usually to diagnose, narcolepsy, you have to rule out obstructive sleep apnea. So say if someone has obstructive sleep apnea, they're getting treated and they get back, it's like, well, doc, I'm still tired. And then they also have those other symptoms where they're tired, they might have that sudden muscle loss and the hypnagogic hallucinations. It's not because of obstructive sleep apnea. They
Yeah.
have narcolepsy, or it's like, okay, well, I know you have a normal thyroid, but sometimes normal people, can be tired with that. And so sometimes, that happens along with that as well. Or as I mentioned before, and unfortunately, especially with women, it's like, oh, well, you're a mom, you're tired,
Yeah.
the kids are, oh, you have 3 kids? That's your answer. It's like,
Right.
no, there's symptoms that go along with it where it needs to be treated.
Yeah, I really appreciate you calling that out. I mean, it sounds like what you're saying is the road to a narcolepsy diagnosis passes through obstructive sleep apnea, right?
Yeah,
Right.
well,
That's
yes,
the
it does.
piece that you have to
It
rule it out before,
yes, well, you
or
have to
deal
rule
with
out
it.
exactly. Well, to be clear, you have to rule out other causes that can cause increased sleepiness. Obstructive sleep apnea is one part of it,
One
and
of
there's
them.
other sleep disorders that you can. And one of the most important parts are you cannot be diagnosed with narcolepsy without a sleep study. Well, majority. There is one blood test you can do where you can take some of their spinal fluid and run a certain type of narcolepsy where you can look for that. Majority of my colleagues, we don't do that anymore because we
Yeah,
have the sleep study. So if
yeah,
someone comes to me and said, "Oh, I've been diagnosed with narcolepsy and I'm on medication for narcolepsy," I'm like, "Oh, when did you have your sleep study?" "Oh, I never had a sleep study." Then that's a big red flag to say, "Hey,
yes.
let's do the proper protocols to see if you actually have that." And I've had that before. There's some people that were spot on. It walked like a duck, talked like a duck, and it was quacking loud. Whereas, like, yes, it's still narcolepsy, but you have to go through those proper channels for it.
Got it. Got it. So let's talk about this interaction between narcolepsy and heart health. So, are there some special considerations that people with heart issues need to consider in terms of managing their heart health and also managing narcolepsy and sleep apnea? So, what are the treatments, which I know you went into in your presentation, but I guess the real focus question is, are there any potential interactions there that folks need to be aware of when they're considering managing their sleep conditions and managing their heart health at the same time?
Yeah, most definitely. So quickly, I'll talk about, obstructive sleep apnea because that's, easier, where when you obstructive sleep apnea is something that's more mechanical that's happening within your body. So you're not like taking a medication to actually treat it. There's been studies where they're trying to find a medication that could like strengthen your the muscles in the back of your throat where it can help with that, but we're not there yet. And with
Okay.
that being said, so using like cap therapy or a device that you put in your mouth to open up your airway, you don't have to worry about that interaction with medications on that. And so from that, that's easy from that. Now, narcolepsy on the other hand, and when you think about, heart health and someone that like might have heart failure or someone that might have hypertension, some of the medications that can be treated, you have to be careful on that. So you look at the medication that you can take because some of that interaction, one of the side effects could increase your blood pressure, could interact with your medications. Or and when you are, for example, for narcolepsy, there's a medication about this where there's sodium oxybate. The key word is sodium. And
Mm,
in my cardiovascular world, and I have a very close friend, he's a cardiologist. You say sodium with him, he does a little twitch. He's like, "Oh no, we don't want that to mess with your blood pressure." And there's companies out there that took that extra step. It's like, okay, I know that this can treat narcolepsy and can help and improve their lives, but we are aware of that part of the high blood pressure part, and so they've made other medications that can actually decrease that sodium content to help along with that.
got
And
it.
also, when people are using stimulants, even though it can promote wakefulness, but it is a stimulant, and one of those side effects can have an increase in your blood pressure, a strain on your heart as well. And sometimes, even with cataplexy, because there's medications that will be able to treat that, there's other medications as far as like SSRIs that can
Mhm.
actually treat that, but those medications can actually interfere with some of the medications that you are taking for your heart health.
Great. Um, this next question is a little bit tricky because, I mean, it's so clear to me that you are so passionate about sleep health, but not every, let's face it, not every physician is. And so, what do you have some tips on how the folks on the call can approach this topic with their primary care physician or another healthcare provider? Because I think a lot of times women are a bit reticent to bring something up, afraid of sort of being minimized, as you gave the example of sort of, having three kids or having a big job or whatever. So do you have some advice on how to broach this topic with their provider?
Definitely. And unfortunately, I've heard that with my patients as well. They came in, it's like, oh, thanks, Dr. Allen. It's like, I've been telling my doctor this all the
Yeah.
time, and you are actually listening. I always say, for people that are talking to the providers, be an advocate for yourself like you're advocating for your children. So your sleep health is like that's one of your other children. Because
Mhm,
if that child's not taken care of, it's hard for you to take care of other people. So I
mhm,
tell them advocate for that and honestly give them supplemental things that can help along with that. So for example, if you was like, look, I'm sleeping, I'm not feeling refreshed, or for obstructive sleep apnea, my bed partner's telling me I'm snoring,
mm,
I'm pausing and breathing. And if you feel like you're not getting the answer that you want, there are a ton of providers that are not, but there's also a ton of providers that will listen to that.
yeah.
And I'm one of them too. And the thing is that I do my best where I talk to my colleagues to help along with that. And the medical group I worked for in the past, they they've heard me talk about sleep till like they're blue in the face. Whereas like, look, if you hear this, this is what it means. For example, as I was giving like the home sleep study that doesn't rule out obstructive sleep apnea. Some of my colleagues don't know that. And the thing is that, those are the most important part. You got to be an advocate for yourself.
Yeah, Absolutely. I mean, and that goes across everything that we talk about at Women Heart. So I really love that. That's so spot on. I've got one more question for you, but it's a really busy Q&A on the chat over here. So I will get to those questions. My question is, and this is, I have a personal interest in this. What would you say are your top tips for some good sleep hygiene?
Okay. And I love that. And so first, I'm gonna throw in a shameless plug again. Go to Sleep Doctor Chris. I talk about that all the time. And it's funny, my friends will tease me about this. Like, yes, I know how to get good quality sleep. I'm watching your videos. So it always starts about the bed. And I have this saying, and I didn't make it up, but I always promote it. The bed is only for three things. They all start with the letter S. So if you're sick, if you're sleeping, we know what that third S is for. So if it's not happening, you're not in bed. And so it's like that wind down time, about a half an hour before bed, like it's getting in that good wind down time and getting in bed. If it takes you more than 20 minutes to fall asleep, get out of bed.
Hmm.
Only go to bed if those three things are happening. Because the thing is that it's just training your brain. It's like, look, this bid is only for three things, and I'm only going to do those three things on there. Now, mind you, I didn't say watch TV. I didn't say scroll on your phone.
Yeah.
It's doing that, and also giving yourself grace. I'm not going to say like, when I'm in bed, I'm not watching TV. I mean, it's going to be football bowl season, so it might be. So I give myself grace for that. Or I'm like, no, let me just look at that one more message. So, you might do that, but you give yourself grace on that. And the thing is that one of the extra things, and I know, we're limited on time, but a lot of people do this mind racing where they have all these thoughts going, 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 going,
Yes.
going. If that happens, just get a piece of paper down and write down what you're thinking. And honestly, you don't have to journal, it's just words. Tired, kids,
Yeah.
spouse,
Yeah.
whatever it is,
Yeah.
hold that sheet of paper up, put it under your pillow. That's telling your mind, like, look, we're thinking about all of this, but we're saving it for another time.
I love that. I love that a lot. Okay, let's get to the questions. There's a lot going over. It's very, very active. So somebody just said, thanks for a great presentation. So I want to make
Oh,
sure I don't skip
thank you.
over that. Denise is asking, with narcolepsy, you mentioned loss of muscle control. Can a person actually pass out?
So the thing is that it's not it's a loss of muscle control, and some people think it's actually passing out, but it's just that moment where like it just happens and you drop. So people are like, oh no, they passed out, but it's an actually, cataplexy that's happening. And it doesn't have to be something that's full.
Mm-hmm,
Sometimes people get it, and I have patients where they just feel it in like sort of their face. And
mm-hmm.
they might be scared. Oh no, they're having a stroke. No, it's like they have a diagnosis of narcolepsy, they feel it coming on, and it's strong emotions. So like if you're laughing, and usually the most common one, and they have a graph of that, laughing. Then after that, it's like anger, surprise, even sex. So that can happen like where it happens briefly. And here's the thing: the key
Wow.
word is briefly. It'll happen, and then you're right back to it. But it's scary because you might be driving, you might be walking, riding your bike, and where it can happen. So that's why I'm really passionate about people finding out if they have that so they can get treated.
Yeah, absolutely. We've got a caller, a participant who's asking, if you already have heart disease, does treating the sleep apnea still help?
Most definitely. And the thing is that, I don't know if my cardiologist friends are watching, but if they are, I apologize if I misquote this, but even when people have like hypertension and it's uncontrolled, one of the treatments that they will talk about is treating like sleep apnea if you have that. So it's actually a treatment for high blood pressure. And the thing is, people that have that, it can either get better or even sometimes occasions resolve. People that have heart failure and we've only been limited on time,
Yeah.
it can still lead to obstructive sleep apnea. There's another portion that's called central sleep apnea, where your brain forgets to tell your body to stop breathing.
Wow.
And treating that can further maximize like your treatment of your heart failure. And treating your obstructive sleep apnea decreases that strain on your heart. So most definitely.
Okay, great. Paula is asking, how do you get off Ambien after being on it for 12 years?
So one, see a sleep professional. And I say that's an easy answer, but then honestly, see a sleep professional with that because that could be another talk in itself. Because my thing is that if you're on Ambien, and for people that don't know that, that's medications that people will use to help go to sleep. When I have patients that have like insomnia or problem sleeping, I try to get to that root cause first. I always tell them that I'm not going to put you on medications unless I have to. And if
Mhm.
you put them on medication, it should be for a short period of time. I had to use a lot of blood, sweat, and tears, less blood, more tears to be board certified in sleep medicine. And one of the things they teach us is when you're using that, it's only for a short period of time.
Yeah,
And I've had people that, yeah, been using it for like 12 years or even longer. And I'm like, well, you're seeing me today for a sleep problem and you're on medications to stop that sleep problem. So we have to adjust that. And the
yeah,
thing is that when you're on it so long, there has to be a specific weaning schedule where you can get off of that and put you on a better treatment plan to get that quality sleep. I always joke with my patients like that are like you. I tell them two things. I've heard it before, I fixed it before. And so that's what happens. Like you have to get off of that. And you have to give them that pathway. And everything is not, 100%. If it doesn't work, we got to find out what that pattern is. And that might not be the right medication for you.
mm,
There's people that will fall asleep, had no problem falling asleep, but they have problems staying asleep. So
yes,
there's certain medications that will treat that, or there could be something else happening.
yeah, yeah. Another question is, what should I do if my insurance refuses to pay for any additional studies to diagnose whether I have a sleep disorder?
Again, I'm gonna sound like a parrot. I'm like, talk to your sleep professional. I take joy of having those peer-to-peer conversations with insurance to tell me why you're not gonna let me treat this patient to help them and to go over. I might even pull up the talk that we had just to go over those things that they could be having because they're not gonna get that. And the thing is that sometimes when that usually does happen, it's sometimes, the provider, and not to throw my providers under the bus, it's like describing why you need that study. And the thing is, it's always about dollars and cents. The reason why insurance wanted to do home sleep apnea testing is because it's cheaper. It's like about $700 to do a home sleep apnea test compared to thousands of dollars to go into that sleep lab. So if I was an insurance company, yes, I want you to do the right test. And I'm the same way. I don't want my patients paying more than they have to, but you have to be the right patient for that. So what you usually have to do is do the peer-to-peer part of it. And there's some loops because even I can give like a point-to-point presentation and they'll look at me and still say, no. And I'm like, geez. So I'll still do the home sleep study
Yeah,
and then it's documentation. If you're still symptomatic and having symptoms, you'll get to that point where you'll get treated. Yeah, like I said, I tell people to advocate for your sleep health like you're advocating for your children. I do the same thing for my patients. I'm going to advocate for them like it's my job, and you're not going to tell me my child can't do or get something.
yeah, absolutely, absolutely. I'm getting fired up just listening to you, Dr. Allen. So this is a great question, I think, for a number of our community and at Women Heart. Snoring seems to be an indicator of sleep apnea. Is there a good way for someone without a bed partner to find out if they are snoring through the night?
Most definitely. And the thing is that there's a couple of ways. One, when I see patients and like I was like, "Do you have a bed partner?" No. And I'm like, "Okay, we'll find out." Because the thing is that even there are apps that you can get
Mhm,
where it'll tell you if you're snoring or not. So you can just always say, "Well, this app's saying I'm snoring."
mhm,
Also, there's other indications too. Like, snoring is only one part of saying that if you might have obstructive sleep apnea. Not everyone that snores have obstructive sleep apnea. So if you have other things outside of that snoring, then you probably have that. So like if you wake up with a dry mouth and you have that
mhm,
glass of water where you have to drink like, oh, then you're like, okay, maybe because you're making up from dry mouth because you're doing that whole snoring.
mhm,
So that's one way to find out if you're going to the bathroom frequently overnight. So when I was talking about those stress signals that are rising when you're pausing and breathing, what happens is the only way to get rid of them is to urinate it out. So if you're going to bed, like going to the bathroom frequently, waking up with a dry mouth, I'm like, you're probably snoring. And it's funny because I get very happy when patients, I always call it the thank you, Dr. Allen appointment, that follow up after just making sure that like all those symptoms that they have, they're like, wow, I'm sleeping better. I don't even wake up to go to the bathroom anymore.
wow,
So there are other indications to know that,
yeah.
that there could be a sleep disorder.
Yeah, absolutely. Denise is asking, am I understanding correctly that having a negative home sleep study will not rule out narcolepsy?
So, so having a negative home sleep apnea test will not rule out obstructive sleep apnea. A home sleep apnea test will not rule in or out narcolepsy.
Got
If you're concerned for narcolepsy, you're going into the sleep lab.
got it. Got
And I, yeah, not too long ago, about a week and a half ago, I was having a very spirited conversation with insurance because there was a patient that, oh no, it was narcolepsy. It was something else that was going on, but you need to go into the sleep lab for that because there's criteria that you need that only a in lab sleep study can do that. So if someone said
it.
that, oh yeah, you have narcolepsy based on this home sleep study, that's incorrect.
Got it. Got it. And then Kathy's asking, I fell asleep early. I mean, I fell asleep easily, wake up every night after 3 hours, and then I'm awake for 3 hours, 3.5 hours, and then I have to nap during the day. What's the question is there any guidance or ideas? I mean, I think the guidance is see a sleep specialist.
So let's get
I've
that
got
part.
that down,
Yes.
Dr. Allen.
So yes. So when that happens, like sleep professional, because someone's like, oh, that's just not narcolepsy. Excuse me. It's like, oh, that might be insomnia. But
Uh-huh.
honestly, there are different sleep wake cycle disorders that could happen. There's people that are like, honestly, when you talk to them, it's like, well, I'm waking up at 3 o'clock in the morning. I'm like, well, what time are you going to bed? Well, I'm going to bed around like, 8:30, 9 o'clock. It's like, well, do the math. That's about 6 hours, almost 7 hours of sleep. That's how much your body needs. Your body's in a different time zone. So it's working, those different types to figure out what's happening. So it's kind of a loaded question
Yeah,
where my thing is that when I tell people, like, if you can't fall back asleep 20 minutes, get out of bed, only go back to when you're sleeping. But honestly, that sleep professional will have that ability to look at your sleep to see where that is so we can figure out what to do to fix that.
great. And the last is more a comment from Annie in Miami, who says that she had severe sleep apnea and the CPAP therapy helped her immensely. And it's something that we as a community at Women Heart really need to take on board to make sure that we're talking about it in equal measure to other risk factors. So it's more of a comment to agree with everything you said, Dr. Allen. As we wrap up, because we've gone way over, but I think it's
Oh,
because
really?
there's
Oh,
so much
sorry.
interest. No, 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 it's not you. No, look, it's the interest of the folks who chimed in here. But I'll give you the last word in terms of what do you hope is the biggest takeaway from our talk today?
Two things. One, sleep is important. A
Yeah,
lot of people, and we were mentioning this before this started, the first thing that people will sacrifice in life is sleep. And myself included, my colleagues included as well. So sleep is important because before you can help anybody, you have to help yourself and make sure you get that part of it. The second part of it, listen to your body. If your body is telling you something or your bed partner is telling you something, listen to your bed partner to say that there might be something wrong with your sleep because that has to be further addressed. And I'll say 2.5 and just don't blame it. I was like, oh, I'm a mom.
yeah.
No, I'm a woman. This happens. No, if it's happening, it's happening for a reason and should be further evaluated.
Absolutely. Well, thank you, Dr. Allen. I've really enjoyed this talk. I've learned a lot. And I want to thank our very, very participatory audience today on this webinar. If you've missed previous webinars on sleep and heart disease, you can always go to our website, womenheart.org, to find the series. I want to thank once again Jazz Pharmaceuticals for sponsoring this really important topic. And I want to thank all of you for being such wonderful and active participants in this conversation today. Thank you all.
Thank you.